I'm now going to move on to the third presentation, which is a pay-for-performance payment incentive model, the goal of which is to improve the quality of active surveillance or watchful waiting for low-risk prostate cancer. And these quality metrics have been developed in collaboration with members of the Prostate Cancer Active Surveillance Project, which we call PCASP. It's a consortium of physicians, including Dr. William Catalona, Dr. Matt Cooperberg, Dr. Stacy Loeb, Dr. Ronald Chen, and Dr. Daniel Lin, amongst others. This demonstration project has been supported by United Healthcare, the largest national payer, in collaboration with Genesis Healthcare Partners here in San Diego. And after much deliberation by the PCASP group, we've come up with the four measures shown in this slide. The first one is the use of an EMR embedded template that captures physicians' assessment of risk and management strategy. And you'll note that we set the bar at 90%. So in order to achieve a point for this particular measure to be successful, one had to have at least 90% of one's patients risk stratified using the EMR embedded template. Measure 2 is the adoption of conservative management, either active surveillance or watchful waiting for low-risk patients. And we set the bar there at 75%, recognizing that conservative management isn't appropriate for all patients, depending on their preference and also sometimes the disease volume. In measure 3 was looking at the quality of surveillance. How well are we doing surveillance? With PSA testing, we suggested at least biannual PSA testing, and that only applies to active surveillance, not to watchful waiting managed patients. And again, we set the bar at 75%. And measure 4, again, reflects on the quality of surveillance, this time with a confirmatory biopsy, which we all felt was necessary within 18 months, and again, only applies to actively surveilled patients. And we set the bar there again at 75%. Now, we recognize that others, and we've discussed this with the music group in letter correspondence in the Journal of Urology, some people feel you can substitute a confirmatory biopsy with genomics or MRI. We felt for a demonstration project and an alternative payment model that we should have a confirmatory biopsy. So these are the four measures that we've introduced for this demonstration project. This is an example of the EMR embedded template. And this is exactly how the template appears in the electronic medical record. And there just are simply 2 clicks that are necessary. The first upper section reflects the risk stratification. And we feel that our physicians have this knowledge at their fingertips when they're busy taking care of the patient. They need to know, is the patient low risk, intermediate risk, favorable intermediate risk, high risk, in order to suggest treatment. So why have an analyst go through the chart trying to determine is it a low risk or a favorable intermediate risk when the physician knows and all they have to do is check off the box and that generates a note that the patient is low risk, and that's followed by what is the choice of management. Is it active surveillance? Is it watchful waiting, surgery, radiation? And that again generates a note. And so they'll get credit for using the template. And if they meet the thresholds of the measures that I just previously discussed, there will be a payment incentive bonus given to the physician. And we've done a pilot study so far, and you can see in this table of only 22 patients that the template was very efficient in capturing risk level. There was one patient with very low risk, one with low, one patient needed to be determined, favorable, intermediate, high, and very high risk. So precise information recorded by the physician without the need to go and do a manual chart review. And similarly, we are able to capture quite accurately the clinical stage, as I previously mentioned, using the HACC template. We recently did a time analysis study to see how much more efficient the template was than a manual abstraction process. And it's really extremely beneficial, probably a fraction of a minute for just writing a query and pulling the data out of the template. And we looked at 135 patients that we've been studying this year and calculated that a manual review of a chart to determine low risk and management strategy took about 6 minutes on average. And if you calculate the number of hours for these 135 patients and at the FTE rate for a data abstractor or a data analyst in the case of the template automation, for these 135 patients, we estimate that the template automation expense would be about $70 versus $1,800 for the manual abstraction process. So about a 26-fold decrease in cost using the template and automatic extraction. So to conclude, healthcare we know is transitioning. It's a paradigm shift from volume to value. The value reflects better quality at lower cost, and we should be cognizant as physicians that the US budget for healthcare is about $4 trillion a year, almost, and it's almost 20% of GDP, which is more than double most developed countries in the world. And the United Healthcare Genesis Healthcare Partners P4P collaborative may be considered an approach to developing an alternative payment model in urology. And the old adage goes, if you're not at the table, you'll be on the menu. So we feel we need to be at the table so we can avoid being on the menu. And we can help drive quality metrics, help drive best practices. And the schematics on the left and right reflect how value-based care is developed and executed. On the left-hand side, you can see you either have a top-down approach where the government establishes the best quality measures through the QPP, which is part of MACRA, MIPS, APM, and then you get measures like PQRS 102, 104. Alternatively, we have the AUA develop the Aqua Quality Measure 9, which I remind you is the conservative management of low-risk disease with active surveillance or watchful waiting, and the United Healthcare Genesis collaboration, which I just described, and that would be a bottom-up approach where we suggest this to the government, but ultimately, I think, and we feel that a collaborative approach with an integrated approach between government and physicians will achieve the greatest experience. So a combination of a top-down, bottom-up approach, meeting in the middle, where we have high-quality metrics that are supported by clinicians like us and implemented through payment systems like APMs through the MACRA legislation will serve our country best. So I thank you for your attention. And David, again, I thank you and appreciate the opportunity to share some thoughts today.